Go. That should work.
That's very cool. Thanks for setting that up, Tom. That's right. Well, good evening, everybody. Welcome to our first M&M of 2024. First one in a while, I understand. So I really appreciate you being here big time. Let me introduce myself in case you don't know. I'm Dan Wilson. I work up at Haywood. I'm the chief of the department as of Ellen Grace resignation October 31st. My assistant is with me tonight, Dr. Mike Shear, who also works with Mike's got a heart for EMS and is a paramedic for a while. Not that long ago, maybe. So we really appreciate your attendance. What I hope to do for you this evening, and this is a 2-numbered event, so we'll get 2 hour credits out of this. The first hour we'll do some didactic teaching on some poisoning toxicology, just to refresh you on what we see in the field. And then the next part of the meeting, of course, will be some chart reviews for you. Just go over some nuances. Please keep in mind that I am here for you. I really appreciate all that you do. You are my eyes and ears in the field, big time. You know that, and I appreciate that. So we're all on the same page. We do the same job. We take care of the patient. It's just a different venue. You know, for you, it's in a 3rd floor of apartment building, a bathroom that's too big or too small for even one person, let alone paramedic crew. You know how that goes and so forth. But for me, it's in the emergency department. So everything we do going forward, I hope, and I'm sure Mike does too, to give you as much as we can to help sharpen your skills and sharpen your minds, because I want you to be clinicians, not just technicians. You know what I mean? I want you to be thinking individuals when you take care of these people. And these people are, as you know, they're our neighbors, they're our friends, relatives, you know, and this person you're taking care of knows a person who knows a person who knows you. You know how it goes. So without further ado, let me go on. I figured maybe a good place to start would be on poisoning. One of the reviews I have for you is just one that just came in the other day, just to kind of overview it and see what it means. There's different terms here and what we do for different drugs and pharmacological agents and toxins. So we'll overlook what a toxicological emergency really is, which most of you know. There's different routes that poisons get in our body, and we'll discuss those and understanding how to assess these individuals. You know, when you get to them, some of them are unconscious, some of them are altered, some of them have the look and the feel that they're a normal patient, but once you start doing your vital signs, you find out otherwise. So poisonings come in all kinds of colors, as you can imagine. And then what we can do in the pre-hospital setting to get these patients better. Sometimes you can reverse them in the field. Sometimes we can't reverse them in the emergency department in tertiary care. So how long has poison been around? Geez, forever. We can read about poisonings way back in ancient literature. You see that in Shakespeare times. In some of his plays, he uses hemlock a lot for a poison. Remember, Romeo and Juliet committed suicide, and that's what they used. Even back in biblical times, there's poison. I mean, just you can go back to the beginning of mankind. Poisons come in all sizes and shapes. At Christmas time, guess what? All these nice decorations around, like mistletoe, poinsettias, they're all very poisonous, very toxic. Interesting enough. And yet let's put this all over the place where we have children. Yeah. So over 4 million poisonings occur annually in the United States. I put this as a general number because it does wax and wane. It's probably going up more and more because there are more and more things out there that you can get poisoned with. You know, new products, new and improved Tide. The biggest thing in the last few years has been those Tide Pods that you throw in the washing machine. Kids like to chew on those because they look like candy. They're colorful. They're yellow, they're blue, they're pink. They look like candy, and next thing you know, they're extremely in bad shape. 70% of accidental poisonings are in kids under the age of 6. No surprise. Why? Because preschoolers, toddlers are very curious, and they like to get into everything. For those of you that are parents, grandparents in the room, or uncles and aunts, you know what I'm talking about, right? Kids are very curious. And that's another thing we can do at the end, you know, just talk about some things we can do in the community to decrease accidental poisonings. You know, maybe do seminars and teach parents how to lock cabinets and put their drugs up higher. 10% of our visits and your responses involve toxic exposure to something. That toxin could be as straightforward as sun poisoning. So that's considered a toxin, although we count it more as a burn or environmental. But toxic exposures can be gasoline in the local garage. It can be carbon monoxide poisoning in a house fire. You can think of a million scenarios there. Okay. And you guys know this, that 80% of our attempted suicides are toxic. They're overdoses. One of the most popular overdoses are over the counter because they're so easy. You know, Tylenol, ibuprofen. A lot of people try to overdose on Benadryl or a combination of any of those. Many people try to commit suicide by taking their prescription drugs. And one of the cases I'll go over with you just happened to be an unintentional overdose on prescription drugs, which we'll see quite often. And polypharmacy overdoses too. Think of the elderly patient that's on a list of medicines this long. It probably would take you 30 minutes at the scene just to go through the med list if you had to do that item by item because they're on so many things. And you guys know as well as I do that the more drugs you're on, the more dangerous it is. So kids with accidental exposure, get this, they have a 25% chance of doing it again. Isn't that interesting? It's really weird. I don't know why, but it just seems to be, maybe it's their genetic makeup, who knows? So poisoning should be considered in any patient that is weird to you. Does that sound like a general statement of what? Anybody that has altered mental status or confusing symptoms that you just can't quite put your head around, that's one of your differentials, besides seizure, besides stroke, besides metabolic encephalopathy or whatever it may be. Start thinking, could this be poison? Dan, why are you telling me to think that? Because the earlier you start thinking through what this could be and sorting it out, the earlier the intervention you can do. And when you start asking your questions and doing your assessment, that'll lead you down the path, right? If you don't think it, you won't look for it. And if you don't look for it, you can miss it. That's a tenet in medicine. I pinch myself all the time when I'm going into a patient's room. I'm going in with a triage note most of the time. And some of the time it's just based on what you tell me. And so sometimes my brain is going in the direction of what you tell me or the triage note, or sometimes I'm not thinking outside the box. You know, so could this febrile patient with left flank pain be more than pyelonephritis? And absolutely true. That could be a lot more than that. It could be a ruptured diverticulum, et cetera, et cetera. So it's important for us to think outside the box. And remember, poisoning can be very intentional, as the Wicked Witch is giving. She has every intention of killing Snow White. And Snow White is going to be the unintentional victim of the poisoning here. She's going to fall asleep until love's first kiss. So the definite, that was my first movie, by the way, when I was a real kid. My grandma took it to. A toxicological emergency, this is either definitions for you. And in an emergency that's truly toxicological, it means an ingestion of, an inhalation of, or surface absorption or injection. You notice the 4 ways there? Of any substance that gives you an adverse reaction. So Dan, are you telling me that an anaphylactic reaction could be a toxicological emergency? Yeah, it certainly could be. Of course, we treat it as anaphylaxis because it's an airway problem, right? But you see, in medicine, as you know, everything tends to overlap, right? So a lot of our patients don't read the textbook, and so they don't go down just one pathway. They decide to do a lot of things. So that's what a toxic emergency is. A toxin is any drug or poison or chemical that causes adverse reactions. So propranolol, albuterol, Seroquel, those aren't toxins. Those are pharmacologic agents. Because it wouldn't look good if a pharmacist down the street at Walgreens is selling a toxin. Hey, toxin for sale. That doesn't sell too well. So technically in the medical literature, a toxin is gasoline, a toxin is carbon monoxide, that sort of thing. Okay. So that's what a toxin is. Poisoning.
I apologize. I was going to
okay.
a little bit because I'm not seeing the other screen.
Poisoning is when. What's that?
Apparently, they're still just seeing the title slide.
Okay. Do you want me to go quickly back, or what do you want to do?
No, no,
They can hear you, they just can't see it.
Okay.
Can you see this on there now?
that's the definitions, yeah.
All right, so Dan, just leave it on this.
Just advance on
Just do it from here.
these?
Yeah, exactly.
Okay.
Or
Yeah.
I'll just stand here and hit it when you're ready.
Okay. Yeah. So I'll just keep it
Just
on
keep
here.
going. Yeah.
Yeah.
I'll just advance.
Oh, thanks. Okay. So poisoning for our talk is just an exposure to a non-pharmacological agent. So a true poisoning wouldn't be a propranolol overdose. A true poisoning would be if somebody overdoses on, like, say, foxglove, for instance. And foxglove is where we get digoxin from. That's the plant. So if somebody starts chewing on foxglove, starts to bloom in the late spring, then they can get ditch poisoning, which will give them what two signs: heart rate and blood pressure. What happens to your heart rate in ditch poisoning? Too slow, too fast. Yeah, it gets slow, right? It's an AV nodal blocker, right? So slow, and it's arrhythmogenic, so you can see dysrhythmias with ditch poisoning. The other thing ditch will do is what's your blood pressure? Drop that blood pressure. So you're looking at a hypertensive bradycardia patient with ditch poisoning. So just a diversion off the slide. Yeah, next slide, Mike, thanks. So easy for you, a little bit less easy for the average patient, although most folks should know this. And this is where teaching can come in. So if you're ever invited to teach or to share, or even at the scene or after the scene, you share this knowledge with your parents. Poison control is the same across the country. So whether you live in Idaho, Florida, or Massachusetts, it's always 1-800-222-1222. The regions differ, obviously, when you go around the United States. When I was up in Vermont, it was at University of Maine, in Providence. No, not Providence. I can't remember. But anyway, that's a ready resource. It's toll free. Yeah, next one. So how do poisonings get there? 4 routes: by mouth, of course. It's probably the #1 favorite route because it's easy. Now, it doesn't entail pain like a needle. You have to rub it on the skin per se. So a lot of intentional poisonings are by mouth for the most part. Inhalation injuries you're familiar with are poisonings. Fire and rescue often get called to these. This is, carbon monoxide poisoning in the wintertime, too much wood in the stove. This could be an industrial accident whereby propane is released, or some gas fumes from an acid tank. When I was in after my first practice was in Johnsonburg, Pennsylvania, it was a big paper mill in the town. They employed 650 people, and they made medium grade paper for magazines, newspapers, cigarette wrappers. And so that mill was going 24/7. And part of the process of doing the pulp and boiling down the pulp to make the paper is to put it in these big acid vats. And the acid that they used a lot of the time was hydrochloric, which is extremely acidic and very poisonous. You put HF on the table, it will eat a hole in the table probably in 10 minutes, just right through it. So you can imagine if some of the guys got exposed to this in the vapors, it would be really harsh. It could burn corneas, burn through skin. If they got inhalation, they would get inhalation pneumonitis, cut their airway out pretty good. ARDS within 24 hours. So inhalation injuries can be really serious. Surface absorptions are things like poisonous plants, organophosphates. So if you ever get called to the scene of like farming accident, or like an ag waste store, Tractor Supply, let's say they're unloading your truck and you're unloading organic fertilizer. Some of that fertilizer may have organophosphates in it, which is white powdery stuff usually. That stuff is instant burn on the skin. It can cause second-degree burns and blistering. It needs immediate washing. So that's the first aid treatment. It's hose. Now, if you want to use a fire hose, go ahead, but watch your pressures, right? Then injection we see deliberately with some of our addicts, unfortunately. But injection can be things like insects and bites and stings. Do all bees leave their stingers behind? Nope. There's only one species of bee that does that. That's the honeybee. Any other bee or wasp, they keep their stinger. Some of these insects, like wasp and hornets, can repeatedly sting. So that's the problem with a lot of patients that are allergic to hornets and wasps. They get the repeated stings, and the more stings, the more chance they have of anaphylaxis. Is something to keep in mind. So general principles that we need all apply. One, prompt recognition that there's a problem. So raise the bar of your index of suspicion. If something is odd, if it's acute, it just happened, start thinking, could this be a toxicologic emergency or poisoning? Number two, and we'll talk a little bit more detail about assessing your patient to identify the toxin and take measures to control it. One, of course, and you're all trained really hard in this, is scene safety. So if you get to the scene of a farming accident, for example, or Tractor Supply, and there's this white substance all over the floor, the first thing you do is stop and make sure fire and you'll get it on the bottoms of your boots and stuff, and then you're contaminating yourself and others. So just keep that in mind. Same thing with acids, carbon monoxide. You can't put that in the building until it's cleared. You know that drill. ABC is always important. I tell my EMTs and paramedics, students, whoever I have, always, always, always ABC, always. It doesn't matter what the emergency is, even if it's a sprained ankle. An ABC assessment and a sprained ankle is real easy. It's quick, right? What's my GP rate? 15, right? APV is normal. So you can tell a lot just by looking at the patient. So make sure you do your ABCs and decontaminate the patient. Next slide. So we size up our scene. We do airway. And airway includes C-spine immobilization, correct? So when you make sure that the patient's breathing, especially if it's inhalation, or if they just swallowed something, or even if it's a poisoning that turns into an anaphylactic reaction, you have to protect the airway. And do you establish a definitive airway if the airway is beginning to compromise? For instance, it's a house fire, and the patient has been in the structure for about 40 minutes now. They're starting to get lethargic. They're coughing a lot. They're starting to get a little reddish around the face. Their tongue is starting to swell. What do you think about that airway? Yeah. Is that a definitive airway or not? Yeah. It's better to put something in there quick rather than wait. All right. So look for secretions or decreased secretions. Is the tongue too wet, tongue too dry, or the lips cracked or whatever. Okay. Next one. So I like this little poem. This is from Rudyard Kipling. He's the one who wrote Captains Courageous and Treasure Island, which are good books to read. I keep 6 honest serving men. They taught me all I knew. Their names are what and why and when and how and where and who. Kind of clever. Why did I put this up there is because those are the 6 questions all of us need to ask in a poisoning situation. What happened? What did they take? What was the substance? Can it be identified? Why? Was it intentional, unintentional? What time? 2 minutes ago, 10 hours ago, can make a difference. How did they ingest it or how did they take it? Where was it done? In an enclosure, upstairs, downstairs, outside, inside, and who was responsible? Usually the patient. Okay. So where do I get my history from? And you guys know this hands down. Can the patient give you an adequate history 100% of the time? Well, yeah. Nope. So do you depend on bystanders? Absolutely. First responders, police department, maybe a neighbor, a guy walking down the street that just happened to see, Johnny completely dump his pills in his hand and throw them in his mouth. Accidental or intentional, sometimes you can't know right away. So when you bring them to me or Mike, you often don't know. We know that there was an ingestion of 100 tablets of 50 milligrams of propranolol, but we don't know if it was on purpose. Okay, and so forth. What was it? Was it a lot, a little, and what were the milligrams? The more details you can give us, the better for the patient's care, because sometimes there's a difference between a drug that has ER or SR or CL on the end than there is just the drug name. For example, when I go over this chart, this lady is on Cardizem, which is diltiazem, and diltiazem comes in regular form, but it also comes in a long-acting form. And unfortunately, she had both at home. So Well, it's what happened. Is there alcohol on board? We don't see any alcoholism in our community. I'm totally unfamiliar with it, so just something to think about. Suicide or not, psych history or not. Thanks, Mike. So you always start with your vital signs and your airway assessment. Does this sound dumb that I'm going over very, very basic things? And I would hope that you would say no, because all of us, me included, really need to really rethink your basics every day. When you check in, clock in, start thinking, Dan, or whatever your name is, don't miss the basics. You'd be surprised at how many times we overlook a blood pressure or temperature. What do you mean they have? Did you take the temperature? Oh, no. Did you happen to know that their heart rate was 140? Well, I didn't really take the pulse very well. So all of us in the room, don't raise your hand, can slip at any time and forget the basics. So that's why I'm emphasizing this. Assess your airway, make sure that they are breathing. Airway may be patent, but the ventilatory rate may be on 3 or 6. Too much airway makes for a bad day, right? So you got to watch that. Look at those pupils, you guys. There are poisonings. We'll go over some toxidromes in a minute that cause either pupillary dilatation, where the pupils are as big as saucers, or where the pupils are pinpoint. A lot of times in our neighborhood, we see pinpoint pupils, do we not? Because we have a lot of opiates out there, and opiates cause pupillary constriction. All right, look at that oral cavity. Do they have burns? Do they have soot? Are they over salivating? Is their airway fast, or respiration fast or slow? Tachypnea, bradycypnea, and so forth. Blood pressure. Here's one that's often overlooked. Is the abdomen distended, or is it soft? Is it hard? Do they have discoloration in their abdomen? Sometimes you guys don't have the time or the situation to actually undress them and look at the abdomen. But it doesn't hurt to put your hand down there and do a quick check. Now, some companies around the country are able to do some fast exams on board and check and see if the belly's got fluid in it. Sometimes that's a hint of a toxicological emergency as well. So if you don't, leave it up to us. But just to make note of it, skin, such an important organ to look at. The largest organ of the body is the skin. And we often forget about it. You know, we're so focused on heart, lungs, or the patient's mental status that we often overlook the skin. So don't forget to look for pallor, for sweating, for modeling. Are they dusky? Does this patient who is altered, does he have something else going on his skin, maybe a big leaking wound? The patient looks pale, may have a big decubitus in the back that's bleeding or oozing, who knows? And obviously you guys do a neuro exam, right? You know right away when you get to the scene, are they alert? Are they able to repeat phrases to you? Or are they confused? Are they babbling? Are they agitated? You all do very well to make note of that in your run sheets. Okay? So management, I've already reiterated ABCs. Airway, C-spine immobilization, breathing, which is ventilation, right? C is circulation. Are they adequately perfusing their tissues? How do I know, Dan? What do dusky nail beds tell you? Are they perfusing? Nope, either that or they're helping. So if they're hypothermic. But if they're dusky around the lips, if they have dusky look underneath the eyes, in the conjunctiva, inside the lip or the tongue, that could be a sign that they're not perfusing very well. A low blood pressure is definitely a good sign that they're not perfusing right. So keep that in mind and do something about it. The first thing we do in the field, of course, is to administer fluids to get that blood pressure up. Okay? Don't forget the pulse ox. Once in a blue moon, when we're viewing charts, you'll see a pulse ox missing. I don't know if it wasn't documented, the pulse oximeter wasn't working. Maybe you couldn't get one. If you cannot get a vital sign for whatever reason, always just say in your narrative, could not obtain blood pressure, cuff broke. Patient refused vital signs. Pulse oximeter broke. You know, my company was too cheap to buy a new one. I didn't put that in there. that would raise all kinds of cane. Hey, look for trauma. Can poison patients be trauma patients? Can trauma patients be poison patients? Absolutely. We see it all the time. How about the car accident going down the road? Was it an intentional drive into the tree at 60 miles an hour? If they wanted to commit suicide, oh, by the way, they took 100 tablets of 100 milligrams of Seroquel before they drove the car. So it's possible. Or had 2 pints of vodka. Oh, don't forget to warn your patient, you guys, so important. If they're febrile, no. But if the patient's chilly, especially if they've been outside in very warm days like this, get your patient warm and decontaminate. If they have something on them that is causing a poisoning, very carefully, I suggest you decontaminate them somehow, wash them down, remove the clothing. Obviously, if the clothing is contaminated with substance that you could get in touch with, you have to do it very carefully. Gloves and masks, as always. Okay. 3 points that are important in toxicologic emergencies, and Mike and I have to do this as well in the emergency department. One, we have to stop the intake of the poison. Well, that's easy enough if it's just a pill over there, right? They stop, and you're picking them up. But what about the patient that is exposed continuously, and they're structure fire, and they're exposed to carbon monoxide? Your first step is to get them away from that carbon monoxide so that they reduce their intake. Simple enough. Number 2, reduce the absorption of the toxin. So if it's on their skin, if they're breathing it in, if they're getting it IV in the hospital, because sometimes we'll actually toxify our patients in the hospital. We can overdose them on antibiotics, shut down their kidneys and so forth. So we have to reduce the absorption. Number 3, we want to get rid of it. So how do we get rid of poisonings? Like, for instance, right now, God forbid, I take 100 tablets of 100 milligrams of Seroquel. I walk out and I start getting really sleepy in the lobby. The first thing you guys are going to do is go out there and laugh at me and call me stupid. Then the next thing you're going to do is to see if, after you do your assessment, see if you can start giving me some activated charcoal, right? If we've gotten away from that for the most part, sometimes in the immediate phase, within 30 minutes of ingestion, especially if it's polypharmacy, poison control is still suggesting some activated charcoal. So, do you guys still carry that? I don't think so. I don't remember. I quickly reviewed the new protocols and I didn't see it. So I didn't think so. Well, it was funny you mentioned anyway. You would give me charcoal only because you'd want to make me a mess. Dan deserves to be black all over. Okay.
Where did I put that super quick?
Yeah. I miss that stuff. That's great. My mom gave that to me once. It was awful. So get rid of, this is how we decontaminate. You get rid of the offending thing. You give this is outdated. We don't give cathartic and charcoal anymore. I should have updated my site a little bit more. In the emergency room, sometimes we'll do whole ballot irrigation. We've gotten a little bit away from that too. This comes in handy. Do we still do it for Packers? Right.
Sure.
Yeah.
Just give them a jug of Miralax.
Yeah.
A jug of Golightly.
Right. Just to get rid of so Packers, as you guys know, are drug dealers or drug mules that pack the rectum with the drug, the cocaine usually or heroin. Next thing you know, the bag's breaking and they get toxic. So what we do is we irrigate the bottle, get all that out of there.
You can also do it for like special situations, like pregnant women with
Yeah.
a big overdose. You sort of throw the kitchen sink at them. That's a
Right.
good one too.
Yeah. So it still comes in handy. Okay. So this is more decontamination, remove the clothing, wash the skin. Do we give oxygen for most of our patients? Absolutely. Can you safely go to a toxic emergency, for instance, and if there are maybe 91, 92, a trick question here, you put them on O's? Would you? Yeah. I would not fault you for putting them on low oxygen because you have an emergency on your hands. Can you guarantee the safety of the patient from point A to the hospital? You can't guarantee that in any case, right? Good things happen en route, you betcha, and you can think of a myriad things. So put them on a little O's is no harm, no foul. Make sure that they get good ventilation. Okay. Next slide. Thanks. So antidotes are substances that we use, and some of these antidotes are in the field and in your truck that you could use to reverse a poison. Probably the most common, the most popular one we use is good old Narcan, right? Naloxone. It's an antidote for an opiate overdose. We see it practically every day, so it's quite commonly used. Rarely, this is important. Rarely is the antidote 100% effective. So why do ER docs typically keep a narcanized, if that's a word, opiate overdose in the emergency department for an hour or two after they get the Narcan? Because maybe not all of the receptors in the body, opiate receptors, receive the blockade of the naloxone. So there might be a receptor or two or three that's still detecting the opiate in the system, especially if it's a longer acting opiate. So as a result, patients fine and dandy, I want to get out of here. You ruined my, so out they go again. We have to repeat the Narcan. Okay. So let's go over a few of the antidotes that we often see. Are any of you familiar with NAC or N-acetylcysteine? We use it for acetaminophen overdoses or Tylenol. Nowadays, we have this intravenously, which is very, very helpful. And we have a regular protocol for it.
You can just, right?
Yeah. So you can administer this intranasally too. Works really well. NAC is good because it helps with an enzyme in the liver that breaks down acetaminophen. The problem is, if you and I take too much Tylenol or acetaminophen, the next thing you know, all that enzyme is burned up. It's a limited supply. So the liver says, I'm done, time out. So the Tylenol begins to build up, and that's when the side effects start to occur: nausea, vomiting, and liver failure. So by giving this, we're replenishing the enzyme, and they can metabolize the Tylenol. Okay? Atropine, you're all familiar with, right? We give it for bradycardia in a lot of instances, especially symptomatic bradycardia. Benzos, do we always give flumazenil or flumazenil for benzo overdose? Absolutely not. I haven't used it.
I've never used it.
I can't remember. Right when it first came out, and the drug company was trying to sell it. That was way back, like my first job in Clarendon, PA. That was back in
I've never even seen a vial of it.
1989, I think. But a pure, absolute, certain, guaranteed benzo overdose, like for instance in a controlled environment in the operating room, when they're using Versed, and let's say the patient has respiratory difficulty because they got 4 milligrams of Versed, the anesthesiologist can give them flumazenil and reverse it. Probably the only environment that's safe. We just don't really use it anymore. But just so you know, okay, everybody knows sodium bicarbonate. We use it for a lot of things. In tricyclic overdoses, it works really well. Those are commonly used older but goody antidepressants. Yeah. So the sodium bicarbonate, because it alkalizes the urine, it makes the urine a little bit more, or a little bit less in hydrogen ion, and it actually pulls a lot of the toxin out of the body, through the kidneys. Calcium, very important electrolyte to reverse hyperkalemia. A lot of patients with poisonings with potassium will get very, very high. And can this change the way the heart beats? Yep. Can it cause rhythm problems in the heart? Can it cause asystole, PEA? Yeah, you bet your dollar. So calcium is very important. Usually we use either calcium gluconate or calcium chloride. I prefer gluconate.
Yeah, you guys probably mostly carry chloride, right?
They pick chloride.
Yeah. Which is a little more sclerosing. So it's, we sort of throw gluconate at people willy-nilly through a little 22 gauge, whatever, who cares. For the chloride, of course, it's really irritating the veins. So you got to make sure you got a nice big fat line for it.
Yeah. Is it calcium chloride cheaper, or why you?
No, it kicks in faster.
Oh,
So for an arrest or
Yes.
for an acute setting, the calcium chloride kicks in faster because gluconate has to get metabolized first.
yeah, here we go. Yeah, HF is hydrofluoric acid. Narcan, oxygen, Glucagon, you guys are familiar with glucagon, right? Glucagon is a hormone of the body that instantly releases glucose stores from the liver. So it's rapid in onset. We use it in beta blocker overdose simply because it has a direct action on the effects of the beta blockade on the beta receptors. And we have 2 beta receptors in the body, beta 1 and beta 2. So by doing that, the glucagon really reverses that in some degree. And it takes a lot of glucagon usually. We ran out of glucagon at Central Vermont. We had a beta blocker overdose, and we were going to Gifford and up to UVM. It's crazy. Okay, next one, then. All right, we'll go run through some talks. How are we doing on time? So, yeah, we're wrapping this up. What is a toxidrome? A toxidrome is a collection of signs and symptoms peculiar to a particular toxin. So there are toxins out there that have their own way about them, and many toxins will have the same signs and symptoms. For example, opiates will have the pinpoint pupils and the fast heart rate. That synthetic opiates on that red will bradycardia, slow heart rate. Stimulants like cocaine, PCPs have tachycardia, tachypnea, flushing, that sort of thing. So there are about 9, give or take, basic types. We'll go through some of these. The anticholinergic toxidrome is the one that is where the patients are very dry. This is a little memnotic that we learned in med school. I don't know if you had this in your training or not, probably. But these are good things to remember because they're quick. If your patient looks very dry, if they're having visual disturbances, if they're really, really hot, tachycardic hypertensive, if their bladder feels full and they haven't urinated for a while, you could start suspecting an anticholinergic poisoning. Okay, some examples down there. Antihistamines, basically Benadryl. A lot of people overdose on Benadryl. Don't forget, you guys, a lot of sleeping tablets over the counter. Guess what's in there? That's Benadryl. So if I overdosed on Unisom or something similar to that, it's probably a Benadryl overdose. Okay. Cholinergic is just the opposite of that. These patients are soaking in their secretions, so they're drooling. They have bronchorrhea, which is a lot of secretions in their airway. They may be tearing. Their eyes are somewhat dilated. These patients have abdominal pain, a lot of cramping. They may have diarrhea at the scene, which is no fun because that means dirty compartment, for you guys. These we don't see extremely often, but just so you know. And the mnemonic for this is that sludge bam at the very top. That's the abbreviation for everything that's on that list. Okay.
What's a really important class of poisonings that you almost certainly learned about in medic school, if not in EMT school, that fit into this category that none of us have ever seen? Think military related. Yeah, nerve gases.
Nerve gas. Yeah, of course, the combat mechs are well familiar. So, what is a pathomimetic? What that means in medical terms is there are 2 areas of the autonomic nervous system. There's the sympathetic side, which is the fight or flight, get go, increased heart rate, blood pressure side. And then there's the parasympathetic side, which is the laid back, low go, bradycardia, slow, low blood pressure side. So these drugs actually stimulate sympathetic side, increased heart rate, increased blood pressure. These patients can be hypothermic, very sweaty. They look like they're really panic stricken all the time. Can cause seizures. What is one of the differentials of a seizure? You go, that's the call, that's the 911 call. You go to a seizure, could be a poisoning. Yep. So keep that on your differential too. Dan, is it really important to think through every differential every time? No, but if you keep your mind outside of the box and kind of think, and when you're doing your history, you can ask, is there any chance that the patient has overdone a drug? Are they on a new drug? Did they buy something over the counter recently? Yeah, so something to think about. We all see cocaine quite a bit. PCP now and then, it's not as unusual. We see methylphenidate is Ritalin, and a lot of folks in the community are on Ritalin or Concerta. Concerta is very similar. There are some other amphetamines that can cause this too.
Crystal meth.
Yes, crystal meth. Yeah.
Yeah, among other things, yeah.
Everybody knows this slide very well. We see a lot of this, unfortunately. These are the pinpoint pupils, hypothermic. Everything is just like, the patient's not breathing, very high. Sometimes their heart gets so slow it actually stops. And then it's a cardiac arrest situation. You have to revive them, and the Narcan just turns them on again. So it's a bad trip, unfortunately. So some of this is prescription from my less esteemed colleagues overprescribing, maybe, or the patient taking too much. Don't forget, one of the big abused drugs these days is dextromethorphan, which is cough medicine. It's readily available. You can buy it just over here at Walgreens or CVS. A lot of people are abusing it, and dextromethorphan overdoses look like an opiate.
More fun though.
Yeah. 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 They enjoy that trip. Yeah. So here's another toxidrome, and I bet all of you are familiar with these, right? The good old withdrawal syndrome. I'm withdrawing from my methadone. I'm withdrawing from my alcohol. So these patients are sick and they're poisoned in a way, although reversed. They're not taking in their poison per se, but they're withdrawing, and their withdrawal symptoms are a poisoning of some sort. So I won't read through all those. You're pretty familiar with that. Okay. So here's a couple other ones that I thought were worth mentioning, which you'll see from time to time. I don't know the industry base here extremely well. If there's any like metalworking or processing plants around that have a lot of metal fumes, you guys know?
We used to have H&R gun company on Industrial Road.
Yeah. Yeah. I just don't know. One of the hospitals I worked with in Newcastle, Pennsylvania, is a little bit less than an hour outside of Pittsburgh. They had a smelting plant close by to the hospital, and so when in smelting plants, you're curating the iron ore to get ready to send to the steel plant for processing. So there's a lot of metal fumes there, nickel and cadmium, iron and so forth. So once in a while we would get poisonings from that. And these patients present flu-like. So metal fume fever is like a flu-like illness. They get fevers and nausea, vomit, aches, and pains. So it's just something to think about. There'd be no way to know this unless the patient tells you, a witness tells you, or you do a scene assessment. If they call you from the scene and you put the history together. Extrapyramidal things, we see this from time to time with our antipsychotics. So if we're using Thorazine, Haldol, Haloperidol, which you're all familiar with, things of that nature, this can cause the patients to go so crazy and have jerky movements or dystonia or kind of walking funny. They look kind of drunk and acting as drunk. What other drugs can cause this besides that is Reglan. Reglan is metoclopramide. We use it for increased GI motility and for nausea. Sometimes we use it as an adjunct for migraine headaches, but this can cause a lot of trouble too. Don't forget, sometimes these patients look seizure-like, and to witnesses, the Jonathan Lately, they'll say they'll call you for a seizure, when actually the patients are awake and they're doing this myoclonic jerking. And that's these rhythmic jerks that they get. You have already seen that? The jerking movement? That's one of these things too. Can I diagnose a hemoglobinopathy in pre-hospital setting? No, not unless you guys are starting to carry, point of care CBC, not colder monitors. But this is something we diagnose sometimes in the emergency department by just doing a CBC. We see that the patients have a lot of methemoglobin in their tox screen or in a CBC, or their red cells just look weird. So when we're analyzing red cells, the machine is looking for red cell at its density, at its diameter, and how much hemoglobin is on there. So when it sees a very pale red cell, or it sees that the red cell is misshapen, or that there's not enough of them, it starts to set off a chain of events. Could this be something that's affecting hemoglobin manufacturing, or is there a poison in the body that's destroying the hemoglobin or taking the place of the hemoglobin on the cell? A good toxin that does like to bind hemoglobin on the red cell is carbon monoxide. It has 3 times the binding power of oxygen. Think about it, 3 times its strength. Now, I'm a chemistry major by way back, so I like to talk chemistry sometimes. I won't bore you with the details. But the bond of carbon monoxide to the hemoglobin molecule is a triple bond. And it takes a lot of kilowatts, if you want electricity type of energy, to break that apart, as versus a double bond where the oxygen is double bonded to hemoglobin. just so you know.
I think you guys, at least some of you guys have a co-oximeter. You know, the Gardner Fire, I think, has a co-oximeter, right?
Yeah.
And that'll pick up carbon monoxide
That's
and
right, you got
methane.
that, yeah.
Our life pack 15s will also do it if you have to like.
Give it the problem.
Yeah, that's cool. Okay. So in conclusion then, and everybody likes to see this item. Hang on, fun to listen to you. But don't forget that in any event, whether it be large or small, whether it be lights and siren call, or whether it's just like not Mary Jones County call the fifth time in a week, don't forget that this emergency could be a toxicological, right? Especially if there's something weird about this. If it came on suddenly, if the vital signs are a little screwy, if you're seeing something on physical gym that just doesn't quite fit what you thought or the witness thought or the caller thought it could be. You know, it's easy to get called to a seizure, altered mental status, fall out of bed, and you get there and it's like, this is a little bit more than that, okay? Always ask those six questions, you know, why you and so forth, okay? Don't forget to be really thorough with your exam. Document what you do as well as document what you don't do or cannot do. It's just as important for the reader of your document, because you know as well as I do that once you type this and sign this, it's a goner, right? This is permanent. This is court record down the road. So careful with your documentation. Tell me what you didn't do and why. Tell me what you did do and why. Because if you explain yourself really well, you'll protect yourself. Okay? And finally, don't forget to think those toxidromes. You guys are welcome to review these. They're readily available. You can just type in toxidromes on Google and it'll bring you up. There are cheat cards available and just to help you out. Okay? Yeah. Any questions? I hope that helped. Just to kind of review poison, because we see it, but we don't. You know what I mean? It's one of those, it's always there, and we get so numb to Narcan reversing opiates that we forget that there's other poisons. Okay?
They're reviewing assessments.
Yeah, we really need to assess your patient. And I know we all do it. In the heat of the moment, it's so easy to overlook the simple, right? Kill these charts. I'll rush in the room and rush out because I'm starting to evaluate a patient, and then the radio goes off. And then nurse says, oh, we need you in 17, or Dan, don't forget to write the discharge papers on in room 8. Oh, and we're transferring this patient to this all at once. And then you forget to ask the patient the simplest question. Okay?
Do you want to go through this oxygen real quick, just with a word about treatment?
Oh,
We'll scan through and just do a quick one word about treatment for each one.
Yep.
All right. So, any ideas as to what you would do for an anticholinergic? So I had a bottle of Benadryl and chugged them. Obviously, give nerve gas because it's the opposite, right?
Yeah.
This one's mostly just supportive. Honestly, there's not a whole heck of a lot to do.
Yeah.
Unless they get like, super bradycardic, but or around tachycardic, but it's really mostly just symptomatic treatment. A lot of these are just symptomatic, but some of them have specifics. Cholinergics actually have a specific treatment if they're bad. If they're mild, whatever, who cares? But if they're bad, someone just went and fell into a vat of fertilizer, organophosphate fertilizer. Yeah. How much atropine? As much as you have.
Yeah.
You titrate the atropine until the drying of secretions.
Yeah.
So you
Because they can
basically
drown in their secretions.
Yeah. So the answer is a crap ton.
Yeah.
Probably more than you have, but yes, that's the right answer. And then 2 p.m. is to bind it, is to break.
How much do you carry on the truck?
3 milligrams probably.
Yeah.
3 or 4.
Okay.
Depends when last time he was restocked. All right, so Pathomedic. I just did a couple lines of Coke and I'm just really, my chest is killing me. It wasn't just the coffee I had. That was
Yeah,
that's it.
I was gonna say you did it last.
Again, I think it's a lot supportive. It also depends on how combative they are. And next to see what it does to 6 of us to hold him down. That was like 107.
Yep.
Yeah,
And there was no control.
Right.
He had to be paralyzed. And
yeah, it definitely, yes.
If they're not quite that bad, They're, you know, it's not a matter of they're so combative, they're out of control, but they're just like, can't stay still. And God, the chest is really, it's a couple lines of coke. My chest is really hurting me. There actually is a specific, more or less, treatment form, which is benzos.
Yeah.
Treatment of choice for sympathic motor.
That's first that are, having.
Opiates, you guys know we don't have to grow up. And withdrawal stuff, you're not going to shoot in the field.
not gonna do it, so.
Extra parameter, so metal fume. I don't know. Never
Yeah.
heard of that one before. Extra pyramidal stuff. I don't expect you guys to know this, but Benadryl will actually fix it, and it's not because of the antihistamine nature of the Benadryl. It's because of the anticholinergic nature of the Benadryl. So it's not an allergic thing. There's another med that you may see on med list occasionally, Cogentin, which is it's like Benadryl, but it doesn't cross the blood-brain barrier. So it doesn't make you drowsy like Benadryl does, but it has the same anticholinergic effect. And a lot of folks who are on like chronic Haldol will take Cogentin along with it to dampen the side effects. And that works really remarkably well,
It does.
both of them. And the hemoglobins, you guys all know this one. What do you do for any problem with the hemoglobin? They had too much carbon monoxide or methemoglobinemia or whatever.
Yeah.
Oxygen.
Yeah, thanks, Mike, for some reason.
That's something that's worth going through real quick.
Brain fart on brain fart and treatments. I would super appreciate it. Yeah. Great. You guys need to take a little break before we do the next session.
We got a couple minutes to do a couple of calls. We're waiting for Sammy to probably have two different questions.
That's right. Yeah.
Different calls to go over.
Yeah. Well, you just.
Yeah, we got like 5 minutes, 5 or 10 minutes so we can knock out a couple of.
Oh, okay. Yeah, sounds good. Okay. So one call we got just recently, this came in by emails. I forget what really this may have been Garden Whip maybe. This is a gentleman I saw yesterday. He's 56-year-old gentleman who was found walking down the street. He seemed a little bit off because bystanders noticed that he had one boot on and one boot off. I think he had a sock on. Yeah, no, barefoot. Yeah. So that's interesting. I didn't know how long he'd been up there. Okay. So this guy comes in as altered. So when they picked him up, EMS reported him as being a little bit altered, boot off. His vital signs were sort of okay. He wasn't overtly abnormal. And they thought, and we thought an initial arrival that maybe it was a psych case. So when you roll in, it was very soon obvious that the guy was not a psych case. He had a little bit of facial droop on the left side, and his head was turned like this. And when you were over on the left, he couldn't look at you. So he had left-sided neglect. He had left facial droop, and the more we dug, the more you see a little leak on the left side. And his left foot was whiter than the pink board in the back. So he was cold. He didn't have a pulse. Looks like he had frostbite on the foot. Yeah, so not so good. Breathing fine. He was a little confused. He could tell me he was in the ER. He thought he was walking to the store to get cigarettes. That was the story. Yeah. Yeah. Yep. This is what I do. I walk to the store. He denied any other substances or alcohol. I couldn't get much more history on him at all. Here's his vital signs, you guys, when he hit my door. His pulse is 63, respirations are 16, blood pressure is 124/88. He was actually 98 on room air, and he was normothermic, like 98.6 or so. So, pretty darn good. He did have a coat on, right? At least there's a coat of coats on it. So his other foot was cold in the toes, so his boot was sort of working, but his left foot was not. I couldn't find any other evidence of trauma on this guy, but neurologically, it was very obvious to us he had left root neglect. So long story short, in working him up, we get a head CT, and guess, I wish I had the images. Next time, I'll try to prepare a little sooner and get some slides up for you to show you X-ray, CTs, labs, and go all the way as far as I can go to where the patient ended up. They ended up at home, at UMass, or wherever, without the end up in Warren. So hopefully we can have it grow. So anyway, the CT scan showed this large infarct. He had a right frontal infarct. It looked like it was in the distribution of the MCA, the middle cerebral artery. And when I did an angiogram, CT angiogram, he had this interluminal clot in the internal carotid artery on the right side. Isn't that weird? Yeah, so there's this clot, yeah, isn't that strange? Yeah. So it was like, oh, well, do we have something we can treat? Let me give you a little stroke background. When we have a stroke patient, we have 3.5 to 4 hours from time of onset until thrombolytic. We have almost 24 hours now to do embolic intervention to get them to an interventional lab whereby they can do thrombectomy and go up and actually move the clot or coil it or whatever we do. So this guy, we didn't know what time the stroke happened. And the fact that we're seeing it on CAT scan precludes any 3 to 4 hour window. Because usually, not always, but usually when the CAT scan is starting to show a stroke and the lack of blood flow, the next thing you know, this stroke's been there a while. Now, the only tool we do not have at Hayward that UMass and tertiary care centers have is a perfusion scan. A CT perfusion scan is a CAT scan that uses specific technology to see, is that brain tissue being perfused? Does it have blood supply around it? It actually improves the prognosis and improves the outcome of a thrombectomy. If you do not see good perfusion, all bets are off. That's kind of how that works. I think that takes special programming. Yeah, and money. Money. Yeah, I won't go there. So, what did I do with this guy? After consulting with stroke neurology and the interventional team at UMass, we decided that our best bet was to treat this guy conservatively. So, he'll be on aspirin. Aspirin, as you know, is an antiplatelet agent. It keeps the platelets from becoming too sticky. And we'll just crop our fingers and hope. He'll undergo an echocardiogram. Any reason why? What's the number one dysrhythmia of stroke? AFib, right. So every stroke patient gets an echocardiogram, and that's what we're looking for. AFib. Anything else we'd be looking for? We got now. We have 4 chambers. Yeah, we're looking for PFO. Story on that in a second. True story. Okay, we're looking at those chambers, you guys, because if there's chamber enlargement, it could give us an idea that the patient has some kind of underlying cardiac disease. Maybe it's cardiomyopathy. Maybe it's LVH. Maybe they have, big thrombus in the ventricle. Maybe they have oversized atria, whereby if the atria are too stretched, it could be a source of a blood clot in the appendage on the left atrium, and that can break off and cause a stroke too. So it's something to keep in mind, even if they don't have it. So there's lots of reasons for that. We also do an MRI. A magnetic resonance imaging gives us a lot more detail as to the brain anatomy, just to make sure that the stroke wasn't induced by some lesion, for example, or some microvascular disease that we just didn't detect. Okay, so we're going, this guy will do all right. We shall see. Speaking of toxicologic emergencies, my case of time. I know you would all applaud and stand for Mike, but I'll see you soon. There you go. This was a tox case that actually came in our doorstep on Martin Luther King Day, just on Monday. 83-year-old female. She presents to the emergency department by none other than my good friends at EMS. There was a Hubbardston call with it. What's back in the I don't know. I couldn't find the run sheet. But her residence is in Hubbardston. Let's put it that way. So here's her story. The call goes out because I'm weak, I'm dizzy, and I'm nauseous. Don't you just know that? It's like, how many calls do you guys get in a week of I'm weak? I even just like blows your mind. But anyway, she's 83, so that raises a red flag, right? Elderly patients can do anything at any time, anywhere. Number 2, She's dizzy and nauseous and more lethargic than she has been. Now, here's her story. Normally, I take diltiazem 120 milligrams a day, which is a calcium channel blocker for blood pressure and heart rate, right? As well as Sotalol, 120 milligrams BID. With the ending of OL, anybody got a guess what kind of drug that is? Sotalol is a beta blocker, much like propranolol or metoprolol. So she's on a beta blocker and a calcium channel blocker. Her cardiologist has just increased her diltiazem from 120 to 240 a day. Again, there's another red flag. Yesterday morning, this was Sunday morning, she came in Monday, she took 120 milligrams of her usual dose, and then that evening, because her cardiologist wanted her to increase the drug, it wasn't very clear on when, she took 240 milligrams of diltiazem, making her daily total of 340 milligrams of diltiazem. Now, the diltiazem that she takes at 240 is CR, which means it's continuous release, which means it's long acting. So guess what, you guys? Not only does she have diltiazem on board, short acting, but now she's taking a 24-hour drug, and it's slowly released over time. So the effect of this toxin, if you will, is on her system for hours and hours. So overnight, she's sleeping, and then she calls the ambulance the next morning because they really don't. That's her symptoms, right? And EMS gets there, and the first vital sign they find abnormal is a heart rate of 32. Ah, gee, I wonder why your heart rate's 32. So it wouldn't take very much time for any well-educated EMT or paramedic to figure this one out, right? I took this drug, I feel this way, and my heart rate's 30. So that's an easy answer for why. So what drug would you give right away to reverse the heart rate? Yes, yes. What, you give 1 gram, maybe 2 grams? Yes. Because you've taken a calcium channel blocker, if you give calcium, that is an antidote, right, to the poisoning. So that's pretty cool. So it goes right along with the lecture. Awesome. Man, you're so smart. So calcium, anything else for the heart rate? Yeah, glucagon would reverse the Sotalol. It may or may not work with calcium channel blockers. It is in the literature, and you can use that, but it's like a secondary block. So I don't get up and up. It's a lot of glucagon. Anything else? My heart rate is 32 and I'm symptomatic. Yeah, atropine. Yeah. Is it safe to administer atropine if it's bradycardia from a drug and not necessarily heart related? Yes. It is a heart issue, right? Because the heart rate is 32. What happens to the cardiac output if the heart rate is so slow? Does it drop? Yeah, right. So this is the difference between a technician and a clinician. Technician says, if A, I do B. If I do B, I do C. A clinician says, I'm doing A because, and if I have A, I'm doing B because, and this is why, and if this doesn't work, I have to do C because B didn't work, right? So all of you in this room, God's honor, are thinking outside the box, good clinicians, from Danny Boy up to the other. Actually, she did improve. Oh, by the way, on DNR, DNI, that saves a little frustration. Have you recently been ill? I thought the EMS did a really good job at history. No recent fever, no recent chills. They asked about drug changes, and of course, that's where they got this history. Have you been in the hospital recently? That's pretty important too, because you know those doctors up there. They like to do all this stuff and then boot you out, and then depend on the EMS community to take care of it. It's like, well, that really works really well. So anyway, they did a really good history. Blood sugar at the scene was 137, somewhere in there. Normal, take it that. History of AFib, as you can imagine, she's had orthostatic hypotension. Wow, and we have her on diltiazem and Sotalol. Okay, I question that one. She's had cerebral vascular disease with a history of CVA. And she has paroxysmal AFib. which I already mentioned, what hyperlipidemia hypertension. Guess who had a patent liver value? This lady, yeah, probably why she had discovered. As a side note, since Tom mentioned, a patent foraminal valley is a hole in the atria between the left side and the right side. So go back to your anatomy, in this one, we had to do an anatomy. So you look at the heart, when we're born, our circulation goes from fetal circulation because you can't breathe, right? You're floating around in the amniotic fluid, trying to take the breath of that. So once you're born, when you go through the birth canal, your chest gets compressed. And when you come out, you'll all remember this, right? When you come out, your chest recoils. That recoil is baby's first breath. And then the baby starts to cry, hopefully. You don't have to spank the kid, you don't have to pinch the kid. They will start to cry. Sometimes they don't right away, and you have to rub their skin or something like that. So that first breath changes the circulation in hours to days from fetal circulation to I can breathe, I'm a human being now. What happens to that foraminal valley? It closes because the pressure's changed. It's largely right-sided pressure when you're a fetus. When you become a live newborn, that changes from right-sided to left-sided. What part of the heart is the biggest part of the heart? The left side. What ventricle's bigger? What ventricle can you palpate better? That's right. So it's all ventricle now, it's all left-sided. Unfortunately, there are people out there whose foraminal valley does not close completely. I was working with a very bright ER doc. His first name is Matt. I won't give his last name. So Matt was just recently graduated from Dartmouth-Hitchcock up in New Hampshire. Brilliant guy. He went to Dartmouth School of Medicine and then did ER residency up there. Did his fellowship in education. He went to education. Brilliant. He was going to work on his master's degree eventually in teaching. So Matt was the brand new father of a second child. They named Penelope, two beautiful children. One afternoon, he's out with his mother-in-law and his wife, two children in Lebanon, New Hampshire, and all of a sudden he gets super dizzy. Now he just vertiginous. The classic spinning, suddenly nauseated. He said, Dana, I collapsed to my hands and knees. I couldn't stand up straight. So they call 911. They transport him to Dartmouth-Hitchcock. He's in the emergency room. Smells like, looks like, acts like vertigo. So when we treat vertigo, it's usually a central processing problem. We put them on IV fluids. We give them meclizine, which is an antihistamine. It decreases the thickness of the fluid in the vestibular apparatus. That didn't work. So they start trying Valium, which is a benzodiazepine, but Valium interacts in the nervous system pretty well to decrease the brain's response to that severe dizziness. Didn't work. Matt was still terribly sick. And they were giving him antiemetics too. So Matt was admitted. He got the golden blood workup from neurology. Bad story outcome. As it turns out, when Matt underwent an echocardiogram, they found a patent foraminal valley. And when they did the MRI and the perfusion scans, guess who had stroke? Matt had a posterior cerebellar stroke in the cerebellum, affecting his balance mechanism. And unfortunately, it's left him with almost permanent double vision, whereby he has horizontal double vision a lot of the time. And so he can't function for very long before his vision is such that he has to rest for it. You can imagine trying to intubate or see a patient in emergency with double vision. The history behind all of this, why did this happen? About 6 to 8 weeks before he walked in the park in Lebanon, Matt was, I don't know if he was jogging, bicycle. He loved the bicycle. So I think it was on a bike. A small accident left him with a non-displaced distal fibular fracture. Guess what happens when you immobilize a fracture of the leg? Increased risk for VT, right? So they did an ultrasound, and sure enough, guess who had a clot in his right leg? So fracture leads to clot breaks off, goes through the patent foraminal valley, goes up to the posterior circulation, knocks him down, stroke. There goes a brilliant ER doc. Right down the yeah, it's sad. Now, the good news is on the other end, he's doing very well. He's actually teaching. He does a lot of teaching and quality control for the med school up there. So he's not doing what he really wants. What he really wants, what I really love, is just being at bedside. I'm glad you brought that up.
It's also the thing that caused Teddy Bruschi's stroke.
Yeah.
Okay, so, want to do the 5 and then we'll, I guess, switch this
5
on.
minutes?
Yeah. So for those of you that are online, I am sending you, if you don't already have it, the link for the next session. Since we have 2 different numbers, I broke it up into 2 different meetings. So give it about 5 minutes and then you can sign back on there and then we'll get started back up again. All right. Right. So we'll see you guys in a few.
Yeah, I would like to know. So I'm glad to see you putting everything on it.
Don't see this.